evening. I'm Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island and tri-state community. I have the great honor and privilege of having Rabbi Yochanan Ivry with me tonight, and we're going to be talking about hospice care. You know, there are different times of the year, different times of life, and certain words have certain implications, and hospice is one of them. The idea that someone who's a beloved member of the family, friend, is not doing well, and we have an idea that they might not survive for a very long time. And we want people to be comfortable, and it's not only the patient, but it's also the family. So hospice care is a very major part of where medicine has gone over the last few years in order to make people's end of life be fulfilling for them and for their families. And Rabbi Ivry is heavily involved in hospice care. I know him from his other job, or other vocation, we'll say as the rabbi and spiritual leader of a synagogue on Staten Island, Torah Emes. He is wonderful, he is empathetic, and he's someone who has given me and my family so much inspiration over the years. So I want to welcome Rabbi Yochanan Ivry.
Thank you. It's a real honor and real privilege to be here and share different thoughts, especially as it pertains to hospice and end of life.
So tell me, first of all, maybe even more personally, how did you get involved with hospice?
It's a great question. A number of years ago, my brother-in-law actually mentioned to me that you might be good to go into chaplaincy as a profession. And at the time, the New York Board of Rabbis was offering an internship with the Jacob Perel Hospice. This was at Beth Israel Hospital in Lower Manhattan, and it was maybe 15 hours a week or so. I started. I found it very meaningful, engaging with different faiths and families, just the stories, Holocaust survivors, unfortunately as young patients as well. We had the inpatient unit at Beth Israel, and it was a very intense place. So it gave me that an opportunity to really learn about the struggles and the fears that we face all when it comes to end of life.
So by definition, tell us about hospice. Does a doctor have to call up someone to be in hospice? Does a nurse? Could a family member call? How do they contact someone? And how do they know and how does anyone know how long someone is going to live or survive?
So generally, it's the physician that refers a patient to hospice care. Obviously, after discussion with either the patient or the family of the patient. And it's usually a 6 months diagnosis, terminal diagnosis that's given by the referring physician. And it's not that cut and dry. There has to be a nurse that assesses the patient and really sees what the patient and family goals of care are. You have patients that are on treatment for cancer, for example, that they may not be eligible for hospice, given that the treatments are more curative. But if it comes to a point where the physician feels that it's not possible to cure the patient with the treatment, and perhaps the treatment is palliative or comfort measures, then that's when the patient is referred to hospice.
Sad to say, I work in a hospital at Richmond University Medical Center. I'm the head of the Department of Neurology, and have a large practice on Staten Island and work all over the city. And many of my patients who do go on hospice care, sad to say, and again, this is a shortcoming of myself and the physicians, sometimes only live a few days afterwards, because until that decision is made, I mean, we're fighting death in a lot of ways, and that's my job. And whether it's supposed to be that or not, it's always so difficult as a doctor, to give up and say there's really nothing else we could do. These are people with brain tumors, large strokes, diseases like ALS or Lou Gehrig's disease. We do know that the prognosis is poor, but we're still trying everything we can, experimental drugs, treatments to the end. And so many of our patients don't get hospice care. And if they do get it, it's only for a few days. How do we educate doctors, nurses, family members, people, patients, to know that if you really don't want any more done, that doesn't mean that we don't care about you. That doesn't mean that your doctor's not going to help you. It doesn't mean that the world doesn't care. So tell us about that, because I think that's one of the shortcomings that I see so much with hospice care.
Right. With the greatest misconception is that hospice care is giving up, and that's farthest from the truth, because we have many hospice patients who actually live longer than the diagnosis that was given, and even longer than expected, to the degree that they have to be taken off hospice because they don't fulfill the requirement, and it's oftentimes because certain medications are terminated, not given to the patient. That sort of, in some way, allows the patient to rebound, and in some ways, become stronger. I had a Mrs. C. I won't say her name, but she lived. She was on hospice for, I would say, a year or more, and she actually graduated. She couldn't stay on hospice any longer. She lived above 100 years of age, and she just thrived. And I think it was sometimes, allowing the body to just allow itself to heal itself, sort of, without all the interventions and medication that sometimes allows the person to live longer than expected.
And sad to say that's a minority of cases. Most people who do go on hospice.
Correct. I mean, like you said, that a lot of most of the patients who are in hospice are on a short-term stay, unfortunately, and that is true. That if more education is needed to the parents and to the patients and the families in terms of when a patient is appropriate for hospice care. But it is a struggle because, you realize that, certain decisions have to be made. Mm-hmm. Whether it's, cancer treatments that have to be, stopped, or if a DNR should be signed.
Which means what?
Do not resuscitate, oftentimes that's a very big struggle for families, for patients to decide. But if it's explained in the right way, that this is a natural process of allowing someone to go, and obviously given the condition of the patient, then I think the message is brought across. In the Jewish liturgy, it's interesting, when we have what's called the Vidui prayer, the confessional prayer, the final prayer. But even in that prayer, we also speak about healing. We ask, God should heal us, even in that moment of recognizing that death may be approaching. Nevertheless, we still include that if God so wills, God should heal the patient.
I've seen in my practice, because I do a lot of work with patients with dementia or Alzheimer's disease, those are the patients that rarely get, at least not in my practice, get to hospice, because it's a prolonged disease. Most people live statistically 8 to 10 years with that diagnosis. And the idea of when you get to the point where you say, I need help, more than just the help that you need with someone who has thinking problems, cognitive problems, has always been an issue. When somebody is clearly can't feed themselves, or gets infections, or skin breakdown, things like that. Obviously, we know at that point. But I think there's always that period of time beforehand that I'm not active enough thinking about things like hospice. I'm going to jump ahead a little bit. We've used the word hospice maybe 50 times so far. If I was watching, if we were looking at my audience here, and you hear hospice, we see commercials for different places like Calvary, places that are hospice hospitals. Tell me what hospice care actually is. So someone's home.
Correct.
There's a caregiver. There's maybe a nurse. What is hospice?
So hospice is a type of care that is given wherever the patient may be, whether it's at home or at a nursing facility, or at assisted living facility, and if needed, at a inpatient facility, and that could be a hospital as well. Certain hospitals have beds specific for hospice care. So it all depends where the patient is, and the care consists of having a regular nursing hospice certified nurse coming to visit, social worker for support to patient and family, a chaplain, which is my role, the spiritual care component, addressing any spiritual needs, whether it's connecting them to their faith-based religious house of worship, or being there as a spiritual support counselor. And we have volunteers is also part of the hospice care, where volunteers would come and read to the patient or do menial tasks that the patient may need assistance with. And of course, and I should have mentioned this earlier, the home health aide, which comes to the hospice patient, whether again in the nursing home setting or home setting, and assists the patient as well in their daily activity needs.
Is it 24 hours a day? Is it? And again, back to that whole idea, and I truly don't know the answer. Is it 24 hours a day, 7 days a week if someone's with the person?
If need be, yes. We do have what's called acute pain or acute hospice conditions where a patient needs to be followed for 24 hours by a specialized nurse that's with the patient. We do have those cases as well. Especially some cases we have, people think, hospice can't, a hospice patient won't be able to be on a feeding tube or a IV hydration. That's not necessarily true. There are hospice patients that do receive nutrition via feeding tube or via IV hydration.
And maybe I'll even go the other way. If you're on hospice care, could you go outside? Could you go for a walk if you could? If you're in a wheelchair or have a walker, could someone help you go outside?
By all means. Not only that, the patients even travel out of state, and we have what's called hospice-to-hospice transfers. So the agency that's caring for the patient in the said location would look out at where the patient would be traveling to, whether it's family or just for a vacation, and they would locate a hospice there, so that the patient could receive continuous care there, wherever they're destined to be.
And most insurances will pay for this? Because again, people always, the burden of costs with regard to that kind of care.
Correct.
Is so difficult.
This is a Medicare, Medicaid benefit. So it is definitely a insurance coverage. It's different than most medical care needs. Hospice is an amount that's given per day that the hospice team receives, and that covers all of the patient needs, medical needs. That includes the hospice medical director, which I failed to mention, is also a very important component of the hospice team. The hospice medical director oversees the care of the patient, the nurse, the social worker, the chaplain, the aides that come and help, as well as the medication. So everything that's given in that amount, the daily amount by the government, is covering for the entirety of the hospice care package.
So I want to get to individuals. And I know over the years you've told me so many stories, places where I grew up, places that I've seen, people I've known who you've taken care of. Do you get to choose, or does the patient get to choose who's their hospice team? So
it's usually divided by area. So for example, I cover South Brooklyn primarily, but I share patients with nurses, social workers that cover that area. But sometimes certain patients need a certain language they're more familiar with, so they would assign, let's say, for example, a Russian-speaking nurse or a Russian-speaking social worker, just to make it easier for them. But generally, it's the area where they are located, and it's a fascinating experience because you get to meet, again, so many different families and faiths, and we all share that common humanity that I think everyone in the end shares on on this planet that we're all vulnerable, and illness could strike in any community, unfortunately. And end of life is part of life. And the thinking is that instead of thinking of hospice as the end of life, it's really bringing life in the end of life. Mm-hmm. It's really making life as meaningful and as purposeful, and being together with family and friends is really the goal of hospice care, giving that opportunity. We have many patients that were married on hospice.
Really?
We had the clergy come in and officiate, for example. We had other celebrations, family reunions, birthdays, of course, different holiday celebrations. I had a patient where I lit the menorah, together with our social worker. So hospice is an opportunity to give that patient that meaningful experience, living as much as they can, and having that very impactful life experience, even towards the end of life.
And tell me about religion or faith. As a rabbi, do you only see, say, Jewish patients or people versus someone else who might be in a different religion? So how does that work?
So generally, I see all faiths. When it comes to spirituality, we all share that common spiritual identity. And there's a famous book, The Needs of the Death and Dying. There are basic needs that each and every person has when it comes to end of life, which could be addressed by any faith leader, really. So it's a very universal approach when it comes to spiritual care. And I've seen cases where patients that I've connected with that were not Jewish, that were for other faiths, Catholic or even, I would say, Muslim patient that I connected with. And it's certain on a very humanistic level that you feel that you have that commonality, that you really feel the pain of others, because ultimately that's what it is. It's showing that the person is not alone, that they have someone there with them.
Do you find any common themes about people finding religion towards the end of life?
So I had a very interesting call one evening. It was actually in the middle of the night from the hospice nurse. I was on call. And she said that she had this patient who was complaining about some type of anxiety and discomfort, and she couldn't pinpoint it to be anything physical. It ended up being something more existential or spiritual. And I actually went to visit that patient. I spoke to her on the phone first, and I went to visit her, and she was completely not religious, with no religious background. But she had this spiritual yearning, and we actually connected a lot. And subsequent to that, I started making regular visits, and she became more, at ease and comforted just by the fact that she was able to talk about her fears and her anxiety and what it means, to die, and the unknown, the fear of the unknown mostly. And that really comforted her.
I mean, it's amazing to think about being on call for being on hospice. And as a physician, we know about on call on a different level, but clearly spiritually, that's so important. I'm just going to segue a little bit because I also know your history and know you very well, of course. Tell me about your role in the hospital. I know I'm at Richmond University Medical Center. I've seen you at the hospital see patients. I don't know, is there one hospital you go to, or is there more than one?
I work as a chaplain, hospice chaplain. I work in several medical facilities where there are patients, one of which is the VA, the Veterans Affairs Hospital, where we have patients as well. But I do visit also as a volunteer chaplain at, you mentioned Richmond University, and as well as Staten Island University, both north and south. Obviously, oftentimes it's not a hospice-related visit, but sometimes it does turn out to be that way. Unfortunately, one of my congregants actually during COVID was at the hospital, Staten Island University Hospital, and ended up with COVID, and it did turn out to be terminal, unfortunately. So then I sort of have that, role as a rabbi from the congregation as well as someone visiting, and it was very moving because unfortunately the family couldn't visit even, so I represented the family as well.
Yes, I mean, that was a terrible time, and
Right.
thank goodness we don't see as much of it now. We still see people with COVID,
Right.
but we don't have that isolation. We've learned a lot about what medically we could do and things like that. So it has come a long way, and really praise to the nurses who would wear these
sacrifice,
these outfits. I mean, we would too, but really spending hours and hours with our patients. I think it was just absolutely a remarkable thing. So tell us back to the hospital a little bit. You've mentioned hospice. Obviously, people need that spirituality. They need to talk to someone. Some things they might not be able to even tell a family member. In the hospital, especially some of the acute care that people get, and you sort of sometimes, everyone's been in the hospital or known someone at the hospital. You see someone knock on the door, "Hi, I am a rabbi. I am a priest. I am a cleric of different religions. Would you like to see me?" Because I think when they ask the question when you're admitted to the hospital, what your faith is, what your religion is. So if you put anything down, somebody will knock on the door. Tell me what you think that the religious person actually adds to the person. How does it help? And do most people actually just wave and say, "I'm okay," or do they want to sit down and talk?
In my experience, oftentimes there is an engagement. There is a interest to have a visit by the chaplain, and I don't mean only as a rabbi, but also as someone who sees other faiths as well. There's often that interest that the common refrain is there's only one, we're all under one God. Even if they're not Jewish, they see me as a rabbi. They say, I ask them, would it be okay if I visit? And they quickly respond, God is God to all, and that's true. And they have that interest because they feel that the importance, that in such a time of illness, and especially if it's something that they're facing end of life, then there's that interest that they want to explore. I remember one of my patients I would visit for a while. He was on hospice for quite a while. He started asking about heaven and the angels, and he himself started having these visions. Oftentimes you have that in hospice where they see what we call, what's the term? Out of this world, visitors. We don't know. My grandmother, I remember, she saw images of people visiting her, and this is very common. I mean, and they say in the hospice where they see heavenly visitors. That's and sometimes it's to accompany them, as they say, spiritually, bringing them to the next world. It sounds a little bit, a little bit out of this world.
The bright light that people see. I mean,
right, the bright light. The famous Elizabeth Kubler-Ross, who did many interviews with patients end of life, and they had this experience, a similar experience. I will just share one experience I had when my fourth child was born. I was at Coney Island Hospital with the bedside of a elderly man with his family there, and unfortunately he was giving his last breaths, and we did the prayers together, and I was trying to comfort the family, being there for the family. And my wife calls me and she said, "I think it's time. We have to go to the hospital." So I had to rush back to Staten Island. A few hours later, my Shlomo was born, and I was holding him. And I must say that feeling, that very similar, very eerie, that here accompanying one life from this world to the next, and then bringing in another life just a few hours later, was very, very synonymous. And it felt, sort of the ideas that at the end we're helping the family. The suffering and pain that people go through is only in order for them to go to a better place. The suffering and pain that a woman gives in labor and delivery is that idea that they're bringing a new life into this world.
Tell me about the family. I mean, we spent a lot about the person, and as a physician, most times people come in not by themselves; they come with a family member, and you could sort of read their eyes about the turmoil they're going through, especially with chronic illnesses, whether it's Alzheimer's disease, Parkinson's disease, ALS, as I mentioned before. And you see the toll on the family. And there's a comment that I always make. My wife is a social worker, that the caregiver many times will pass away before the person with the illness because they don't take care of themselves. And that happens a lot. So in your role, both in the hospice, both in the hospital, both as a rabbi of a congregation out here on Staten Island, tell me about how do you interact with the family? I think we're giving part of it saying how spiritual people get, but obviously there's a lot of anger sometimes. And I think I've seen more of the anger with the families than even with the patient. People are resigned and understand that they're ill and they're going to have a problem, and they're trying to be strong for their families. But just the idea, and I really want to focus on the families in the last couple of minutes that we have. What examples that you have, and really, how do you comfort a family person who's angry?
Right.
And I think that's the hardest thing that I have as a doctor, is I don't know what to say sometimes. I could just give the facts. I could talk to them. I could be, of course, as empathetic as I can. But the answer is they're right. This is a bad thing that's happening. And again, I always think about things as good and bad. And I always respect the hospice people because death to me is bad. And that's me failing at what I've tried to do. And it's been a lot of years I've done this, but it really still ultimately becomes that. I'm fighting that. I'm fighting illness. I'm trying to get people as good as we possibly can, versus a lot of times hospice, of course, is trying to cope with the situation. So tell us about family and what you think about and how you interact with different kinds of situations.
So I always share the story of the young girl who was praying in the synagogue, and the rabbi says, "What are you praying for?" She says, "Next week is my birthday," the little girl says, "and I'm praying to have a brand new bicycle." So the rabbi said, "I hope God answers your prayers." Next week comes along, and the rabbi's looking for the girl. She sees the girl. She says, "So did God answer your prayer?" She says, "Yes." She says, "Where's the bicycle?" She said, "Unfortunately, the answer was no." So we don't always get the answer we want, but it's certainly very difficult, very challenging for families. I mean, you have families that feel that they didn't choose this role, and oftentimes you have to tell the family they need to have self-care. I remember there was a patient with Alzheimer's, with a husband. We were encouraging the husband to go out and get some exercise and get some fresh air, constantly at the bedside, and and besides the business that he had to run. It was very taxing on him, but he needed that self-care. Other times you have just the guilt that the families have. It's something we have to address. But at the end of the day, we always have to say that there's a bigger picture. We don't always understand all the details, but we have to, in some measure, accept. That's the famous blessing we say in Jewish tradition when someone passes away. Baruch dayan ha'emet. Blessed is the true judge. We don't always know why the judge decides certain cases this way, but at the end, it's the
I'm going to thank you for being here. Our half hour went by very quickly. I wish we had some more time to talk. Your experiences are wonderful. And please, thank you, and thank you for everything that you do.
Thank you.
Have a good night, everyone.